Utilization and charges for the treatment of headache, cervical spine pain, and low back pain, MD, DC, PT, and referral care. We have the unusual opportunity to look at nearly a decade's worth of healthcare data and compare utilization and costs covering three primary complaints across three primary health disciplines in a series of 3 articles spanning 40 pages in the Journal of Manipulative and Physiological Therapeutics, published in 2016. These are entitled Variations in Patterns of Utilization and Charges for the Care of Headache in North Carolina, 2000 to 2009, a statewide claims data analysis, and another for the care of neck pain, and yet another for the care of low back pain. Comparisons were for MDs, DCs, and PTs, and included combinations of these and referral care to specialists. It's important to note that this study was focused on state employees, retirees, and dependents in North Carolina, and that in North Carolina, patients must be referred from an MD or DC to receive PT care. Further categorization was that the MD group included a host of practitioners, including general practice, internal medicine, neurology, OBGYN, physical medicine, geriatric medicine, osteopaths, nurse practitioners, and podiatrists. Referral providers were hospitals, surgical centers, and emergency medicine. Let's take this opportunity to first combine the discussion of what is similar across these 3 studies before proceeding to the specifics of each study. So how were charges calculated? They did not use an episode of care as sometimes analyzed when viewing costs, but instead the total allowed charges were calculated by summing the payments made by both the patient and insurer for every given year, comparing within-year relative differences in costs between patterns of care. Also, costs were not adjusted for inflation. And for each fiscal year, pharmaceutical claim data was linked with medical claim data. The major categories of claim type data were a professional office visit to an MD or DC, advanced imaging, radiology, physical therapy services, and surgical services. There are some limitations and concerns with these 3 studies' analysis of North Carolina health insurance databases, specifically the possible inaccuracy of diagnostic coding and variability in management and treatment codes. In this study, there was a lack of availability for risk factors for the entire decade of the analysis, only from 2006 on. Remember that these studies were a focus on state government employees for North Carolina, again limiting extrapolation to other populations. All of these create the potential for provider underrepresentation. Risk scores take into account factors that may affect utilization and charges, including age, gender, primary diagnosis, comorbidities, and use of prescription drugs. Risk scores help illustrate the variable complexities of treating one particular patient versus another. There is then the expectation that higher-risk patients utilize health services more, with resulting higher charges in comparison to a low-risk patient. For this study, by using data from patients in the middle, the lowest and highest risk patients don't influence the data so that it reflects more of the average or more typical patient. Martin et al. Reported that the largest proportion of increased costs for medical expenditures for spine-related problems were inpatient hospitalizations, with charges increasing 37%, outpatient costs increasing 18%, prescription drugs increasing 139%, and emergency room visits increasing 84%. Nationally, one study indicated that patients with spine problems showed a 65% increase in medical expenditures from $4,695 in 1997 to $6,096 in 2005 per person. The current studies examine whether this is consistent with the findings in North Carolina. Now to the specifics. Let's begin with headaches. A reminder that the World Health Organization ranks headache among the most disabling conditions for men and women. Clearly, migraine, being the most common severe type, costs estimated billions for just the U.S. Yet this study does not focus on headache type tied to cost of care. Only a primary ICD coding of headache was used. No differential for type of headache was included. If the patient was diagnosed with any type of headache, they were included. Subluxation was not one of the codes used as an identifier, and no episode of care requiring episode length, time lapse between visits, and time to recurrence were used. In this North Carolina population, the number of headache claims in 2000 was 9,587, increasing to 22,870 in 2009. And the total charges for headache in 2000 were over 15 million, but in 2009 increased to over 46 million. In 2009, unadjusted analysis showed that MD care was on average 15% less expensive than DC care. 65% of claims in 2009 were MD only or MD referral. A mere 10% were DC only claims. Referrals associated with MD-only care were much more expensive than referrals associated with DC-only care. DC-only and MD-DC care patterns were less expensive on average than MD-only and MD-PT care. And now to neck pain. According to the 2010 Global Burden of Disease report, neck pain ranked 4th in terms of disability among 291 health conditions, and 21st in overall burden of disease when measured in disability-adjusted life years. Patients were divided into two types of neck pain, uncomplicated and complicated. Uncomplicated included degeneration of cervical IVD, cervicalgia, cervical brachial syndrome, torticollis, ossification of the posterior longitudinal ligament, post-laminectomy syndrome, spasm, and other musculoskeletal disorders. Complicated included cervical myelopathy with either spondylosis or degeneration of the IVD, cervical stenosis, injury to cervical nerve root or brachial plexus, cervical nerve root, brachial neuritis, or radiculitis. The numbers of uncomplicated neck pain patients seeing MDs increased 185%, whereas the number of patients seeing DCs decreased 16%. The numbers of complicated neck pain patients seeing MDs increased 158%, whereas the number of patients seeing DCs increased only 52%. On average, over the decade, the combination of MD-DC care incurred greater total charges per patient than the combination of MD-PT. The combination of MD-DC referral care incurred fewer total charges per patient than the combination of MD-PT referral care. For uncomplicated neck pain, risk-adjusted mean charges were significantly lower for all patterns of DC care compared to patterns with MD and PT, with the total allowed charges, depending on the year, 41 to 80% lower on average. These findings were similar for the complicated neck pain cohort, with a few exceptions noted in isolated years. Generally, the total allowed charges were on average, depending on the year, 54 to 84% lower for DC patients. And finally, low back pain. Some preliminary information. The number of low back pain cases in the U.S. increased from 14.8 million in 1997 to 21.9 million in 2006. 1 to 2% of adults in the United States are disabled due to back pain. Chiropractic care experienced a 57% increase in patient visits from 2000 to 2003 in the U.S., while the mean costs per patient and per chiropractic office visit have remained stable over time. Similar to neck pain, the types of low back pain were categorized as uncomplicated and complicated. Uncomplicated included facet spondylosis, lumbago, spondies, muscle spasm, and strain sprain. Complicated included myelopathy with either spondylosis or disorder of the IVD, lumbar stenosis, sciatica, compression of nerve root, neuritis or radiculitis, numbness or tingling. The inclusion criteria were met for 2 million uncomplicated low back pain patients and for 1 million complicated low back pain patients. For uncomplicated low back pain, the number of patients increased 138% from 2000 to 2009. And for complicated low back pain, the number of patients increased 177% from 2000 to 2009. For uncomplicated low back pain, total allowed charges increased by 45%. MD only, DC only, and MD DC care were consistently the less expensive patterns of care. And for complicated low back pain, total allowed charges increased by 38%. DC only, MD only, and MD PT care were consistently the least expensive patterns of care for complicated low back pain. When comparing MD only to DC only patterns of care, MD only care was more expensive than DC only care for uncomplicated and complicated low back pain. Important to the analysis and discussion of the findings is that North Carolina changed a key policy. This policy change of treating chiropractic care as a specialty service increased the co-payments for DC visits by 20% to 100%. The data used by Davis et al. From the Medical Expenditure Panel Survey between 1998 and 2008 suggests that the primary driver of increased spine care expenditures over time was not due to charges in DC or primary care expenditures, but instead resulted from a significant increase in specialty medical care. Telling is that the Rand Health Insurance experiment found that the use of chiropractic care was cut in half when patient cost share was 25% or more of the visit cost, and indicated in these studies utilization of DC care did not keep pace with MD care. Yet in two prior studies, when a DC was the portal of entry provider, the total cost was lower when compared to low back pain patients that had other entry points into the healthcare delivery system, such as physical therapy or a medical specialty. Another study in a commercially insured population showed low back pain episodes initiated with DCs cost 20% less than those initiated with medical physicians. So some observations. These are not studies of effectiveness, so we are unable to draw conclusions regarding discipline-specific comparative value. These are isolated studies of a specific population in North Carolina, which may not necessarily match other states or populations. Remember that inflation was not factored in, so it's difficult to determine how much the increases were due to increases in services versus reimbursement patterns or frequency of utilization, etc. It does appear from other studies, though, that compensation for services rendered by chiropractors has not risen proportionally to increases in utilization or compensation to other providers. Patterns of access seem affected by whether the provider is designated as a specialist and with associated increases in copay. It does appear that in future discussions regarding our place in the healthcare process, we may need to consider unforeseen consequences with regard to being recognized as an expert and being assigned the status of specialist. If the result is payers require more copay from patients, we may be working against our goal of more access and changing the apparent belief by many who do not seek chiropractic care because they perceive us as too expensive. Ironically, as demonstrated in the headache study, it appears as though patients switched to MD care when chiropractors were designated as specialists, thus appearing more expensive to the patient, which then may have increased total expenditures. Future similar studies should be performed across the U.S., as should matching comparative effectiveness studies to determine the relative value of each provider's management.